Good morning, good afternoon, and good evening, and a very warm welcome to today's webinar. We will be sharing with you today an exciting initiative called Scaling Up RAS in a community-based initiative in Zambia, and we'll be sharing the final results from the MAMaZ Scale programme. I was delighted to see that over 60 people had registered for today's call. It's wonderful to see those high levels of interest. Thank you again for making the time to join us. My name is Caroline Barber, and I'm the Chief Executive of TransAid, one of the partners on the MAMaZ Scale programme, who have had the privilege to be involved in this really important and exciting initiative. I'm also joined by a wonderful group of presenters today. Due to time restrictions, I won't be able to introduce everyone at this stage. We will introduce as we go along. And just a couple of quick admin housekeeping points from myself. We expect the webinar to run between 60 and 90 minutes today, depending on the amount of questions that we have. We will be recording today's call based on feedback from participants who aren't able to make the live session, so just to make everyone aware of that. All attendees have been automatically muted on joining, but please do feel free to post your questions in the chat function as we go. We really do want this to be a discussion, and we really welcome your contributions. For that reason, there's also a question and answer session at the end. And next slide, please. So just a very quick outline of the agenda for today. We'll be setting the scene. We'll be hearing about the malaria context in Zambia. Then colleagues will be taking you through the MAMaZ Scale approach. We'll be sharing some of the headline results from the programme. Then there'll be the question and answers, some final comments, and then we will be wrapping up and closing. Next slide, please, Shadi. So I now have the great pleasure of handing over to Hans Ledfeld. Hans is the Director of Access and Product Management and the Severe Malaria Lead at Medicines for Malaria Venture. And we're really pleased that you could join us today, Hans. Over to you.
Thank you very much, Caroline, and thank you to the organizers indeed for the opportunity to be part of this important webinar. I'm pleased to share a few words on the role of artesunate rectal capsules in the pre-referral management of severe malaria patients. In 2020, malaria deaths increased by 12% compared to the previous year, to an estimated 627,000, mostly children under the age of 5. And it is estimated that 2/3 of those additional deaths were due to service disruptions during the COVID-19 pandemic. Each case of severe malaria is unfortunately an example of uncomplicated malaria taken care of too late or not adequately. And that is why effective case management is critical. For patients in remote communities where comprehensive medical care is not immediately available, a pre-referral intervention with artesunate rectal capsules or rectal artesunate is indicated when severe malaria is suspected. This single dose of rectal artesunate will benefit the patient during the time it takes to travel to a referral health facility, where then parenteral treatment with injectable artesunate must be provided for at least 24 hours and until the patient can take oral treatment. The third step in the continuum of care is a 3-day course with an artemisinin-based combination treatment, or ACT. Now, MMV supported 2 manufacturers, Strides and Cipla, both from India, with technical assistance to develop their rectal artesunate formulation and achieve WHO pre-qualification in 2018, making these products eligible for donor-funded international procurement. Between these 2 WHO pre-qualified products, they are now registered in 20 countries, and over the period of 2018 till 2020, approximately 3 million WHO pre-qualified artesunate rectal capsules were procured by over 20 countries. And the topic of this webinar, this pilot project, which then was further scaled up in Zambia and started in 2017, was initiated through a call for proposals by Medicines for Malaria Venture and then funded jointly by TransAid and MMV. And Medicines for Malaria Venture is also proud to be part of the group of funders of the 3-year successor project, MAM Scale, the subject of this webinar that was implemented between end of 2018 and just end of December last year. And these projects in Zambia have been very successful, resulting in an 84% reduction in severe malaria case fatality rates among young children. And that reduction in case fatality rates was seen in both the demonstration and scale-up districts, suggesting that rectal artesunate can be used effectively in real-world conditions. And some of the real success factors were the investing in communities, the community ownership from the start, and having well-trained community health volunteers. Second, a functioning referral mechanism in place that was supported by the community with, for example, emergency bicycle ambulances. And indeed, a well-assured continuum of care, starting with pre-referral rectal artesunate, patients then followed up with injectable artesunate at the health facility, and then a 3-day course of an ACT. In concluding, the Zambia results make a very important contribution to the global evidence base and can be considered along those of the Community Access to Rectal Artesunate for Malaria, or CARMAL study, that was implemented in the past 3 years in Uganda, Nigeria, and the Democratic Republic of Congo. The results from this innovative work in Zambia, that you will hear more about from the next speaker, demonstrated rectal artesunate administered at the community level by trained community health volunteers in combination with a range of supportive community managed interventions can make an effective contribution to the national efforts to combat malaria when embedded in a well-functioning continuum of care. And with that, I'm pleased to hand over to the next speaker. And that is supposed to be Ernest Chanda, the MAMaZ Scale Technical Coordinator in Zambia. Over.
Good afternoon, everyone. My colleague Ernest is having connectivity problems, so I'm just stepping in temporarily, but we're hoping to get him back onto this call. I'm just going to give a very quick overview of the project approach. My name is Kathy Green. I'm a technical advisor to the MAMaZ Scale project. This was a 4-year intervention. It started with a pilot project, which was just 12 months in 2017. That was implemented in a single district. We then scaled up to 10 districts over the period 2018 to 2021. So overall, we're looking at a 4-year intervention. So the severe malaria innovation was targeted to children aged 2 months to 6 years. The whole intervention was implemented in partnership with the National Malaria Elimination Centre, which is part of the Ministry of Health in Zambia, and district health management teams. Next slide, please. So the challenge in Zambia is that rural communities seem to encounter many delays and barriers in accessing treatment for severe malaria in children. And if we look at the World Malaria Report of 2020, there were an estimated 8,946 malaria deaths that occurred in 2020. So this includes deaths registered at the health facility, but also those that are estimated to take place unseen away from the health services at community level. And many of these deaths are avoidable. Next slide, please. So there are many different barriers and delays at community level, ranging from low awareness of the severe malaria danger signs, so an understanding of when and how to act when danger signs are observed, to lack of affordability, so there are costs incurred in going to the health facility, and also some very practical constraints around lack of food. So when families take a child to the health facility, they often have to feed themselves. So they need to have food readily to hand. They also need to be able to feed family members back at the household. So lack of food is a major practical barrier. Lack of emergency transport options is an issue as well. So a lot of families don't have a means by which they can get to the health facility very quickly. And that is sort of reinforced by challenging terrain in some areas. Next slide, please. So the project's approach at community level was to offer a very innovative training for community health volunteers, which not only enabled them to relay some very important information about severe malaria and what steps to take when danger signs were observed, but also to mobilise the community around a severe malaria agenda. So the community health volunteers were trained in how to administer RAS, so how to store it safely, how to recognise the danger signs in children, how to follow up with children, etc. So a very comprehensive training delivered in a very innovative way. Communities were supported to establish systems which helped to break down some of the barriers and delays that were preventing a quick response to a health emergency. So they were supported to establish food banks, which helped with the issue of not having enough food readily to hand, and also emergency saving schemes, which helped reduce some of the costs associated with going to the health facility. An emergency transport system was set up in 4 districts based on bicycle ambulances. That was very relevant because there was a strong bicycle ambulance culture in those districts. So this was a system that was available 24/7 at no cost to communities. And all these systems were promoted across the entire community, with the community health volunteers really encouraged to make sure that those who were a bit marginalised, who were socially excluded within the community, could actually access these very important safety nets. So the work at community level was underpinned by a community monitoring system. So the community health volunteers collected data on their activities, as did the ETS riders, the emergency transport team riders. So they were able to document what patients they saw, how they got to the health facility, whether they were given RAS, whether they were followed up upon their return to the health facility. So a very important way of documenting the activities of the CHVs. Next slide, please. We were talking earlier about the fact that the CHV training was very, very innovative. It was designed for a low literacy context. The reading and writing skills amongst some of the volunteers weren't that good, so it was very important to use techniques that were easily assimilated and could be shared with the wider community. So there was a very large emphasis on song and dance and the use of communication body tools to relay key messages and actions. And just to give you an example, the CHVs would learn some of the danger signs of severe malaria, and if we take one of them, fever, they would repeat the word fever in the local language and then demonstrate. And we can see a CHV here who's got her hands crossed, pointing up to her shoulders, and then she would shake and demonstrate the sign fever. And what we found in communities was even the very youngest children could demonstrate the danger signs, and they quickly were disseminated throughout the community. So very useful approach. Next slide, please. At health facility, district and national level, there were interventions with the health facility staff. They were providing refresher training in severe malaria case management. It was very important to have an end-to-end approach where we worked at community level, but also at health facility level. The focus of the training covered how to administer injectable artesunate, which is part of the treatment for severe malaria. What we found was that a lot of the health providers had some training in severe malaria, often when they were in their training schools, but it was some time ago, so a lot of them needed a refresher training. Also at health facility level, there was a strong focus on strengthening linkages between the health facilities and the communities. And the way in which that happened was that the health workers were fully involved in the training of the CHVs. So when the community health volunteers were trained in RAS and in how to mobilise their communities, the health workers played a major role in the training. So they really knew what was expected of the health volunteers and also the riders. The health facilities also were encouraged to provide supportive supervision to volunteers, and I think we all know how important it is to have regular supportive supervision. That really helps with the motivation of the community health volunteers. At district level, the districts were encouraged to lead key activities. They were also involved as key trainers in all the major trainings. We worked with focal persons who took responsibility for specific issues. So, for example, within a district health management team, there isn't a lead person for emergency transport at community level, and therefore the DHMT appointed a focal person to take on that issue and to lead on it. There was also a big focus on monitoring drugs and commodities at district level and making sure that any shortages were identified very, very quickly and dealt with. At national level, the two demonstration districts that we worked in, that was Chitambo and Serenji in Central Province, they acted as sites of learning. So policymakers, provincial health staff, and other district staff, and also development partners were invited to the demonstration districts to see the work in action. Our local team also participated on national fora such as the National Technical Working Group for Malaria, and inputted readily to exercises such as drugs quantification exercises for injectable artesunate and rectal artesunate. Next slide, please. In April 2020, with the start of the COVID-19 pandemic, we quickly adapted the project to take on a COVID-19 focus. At national level, we worked with government to develop a set of COVID-19 community engagement guidelines using the experience that we'd gathered at community level over the past few years. The protocols that the community health volunteers and the ETS riders were working with were adapted to make sure that they were operating in a COVID-safe way, and that was vitally important. So all the volunteers and the riders were given a refresher training in that. In terms of awareness raising on COVID-19 prevention and response, local language posters were produced, and also a series of community radio programs were delivered, quite often with the DHMT in the driving seat with those ready to answer questions, and therefore providing very clear, very reliable information for the communities to listen into. The food banks that I mentioned earlier were topped up with emergency supplies of food. There were quite a few instances where, because of the lack of mobility around the community, the inability for households to leave the community for work, and that households suffered some major issues with food shortages. There was also an emphasis on installing hand washing stations. Next slide, please. As part of the COVID-19 response, there was a real concern that cases of gender-based violence were rising in the communities. And so part of the response was to set up a campaign. Again, community radio played a major part in that campaign, and also there were local language posters produced in a number of different languages. You can see here one in English, but there were many other language posters produced at the same time. On the community radio programs, there was a live phone-in format with Q&A, so that callers could ask some quite pertinent questions about gender-based violence. And what was quite interesting with these programs was that the community health volunteers were within these programs, they were answering the questions and giving very practical examples of some of the changes and the mechanisms used in their own communities to deal with gender-based violence. So they were pretty effective. And overall, this campaign was timely because I think internationally there was concern about a rise in GBV cases. Next slide, please. So I'm now going to pass on to my colleague Dennis, who is the operations manager for MAM Scale, and he's going to take you through the projects monitoring and evaluation framework and also present some of our headline results. Thanks, Dennis.
Thank you so much, Kathy. And good afternoon, good morning, good evening, everyone. Not very sure of the time differences. However, I'm going to dive straight into our monitoring and evaluation framework. All the issues that my colleagues have presented on, the project had to find a way of measuring and tracking all the results of the various interventions that we have been implementing. So we had project M&E framework, which contained first we had a baseline and an end line. So like we have mentioned, this project started from a pilot until last December when we actually concluded. So between this period, we conducted a baseline in 2019 and an end line in September 2021. Apart from that, we were utilizing the health management information system data, which is which is being operated, and also we're utilizing the community monitoring system. So this community monitoring system is a system that we had as a project where our community health volunteers and riders collected CMS data on a monthly basis and submitted this data to the health facility for onward reporting to the district health office, which we could tap in and also use the data for analysis. Apart from that, we also implemented a RAS verification exercise. So this RAS verification exercise, we had three during the period of the project. The first one being in 2018 and the last one being in 2020. However, I'm going to elaborate a bit more further when I reach to a slide that specifically talks about the RAS verification exercise, so that people can understand what we are tracking using this this gadget. Next. Straight in the results, like we may have mentioned, we started this project implementing in one district and we scaled up to 10 districts. So these districts were across 7 provinces, which I will share with you the names of the provinces and the district at a later stage. But you can see the results that from pilot up to when we ended the last phase in December, we actually increase our activity exponentially. So for example, during the pilot project, we intervened in 45 communities, but at full scale up phase, we had intervened in 1,272 districts. Similarly, intervention health facilities were in 8 at pilots, and at scale up we were in 217. During the pilot, we covered a population of 54,000, and when we did the scale up, we reached a population of 900,000, which represents an increase of 1,564%. Health workers, we trained during the pilot, we trained health workers, like my colleague Kathy said, we trained health workers in case management, severe malaria case management. During pilot, we trained 31, and at scale up, we had reached 2,241 health workers. We also trained community health volunteers in the administration of RAS and community awareness. And also ETS riders were also trained to respond to emergencies. So we trained at pilot 477 health community health workers, community health volunteers, and at scale up we were at 3,251. ETS riders at pilot were at 66, at scale up we were at 343. So basically, you can see that from pilot to the next phase, we had scaled up quite exponentially, which helped us so much in actually achieving some of the positive, most of these positive results that we are sharing today. Next slide, please. Like I mentioned, we started in one district, and by the time we're scaling up, we're across the country in 10 districts. And those 10 districts were spread across 7 provinces, which I'll mention. So we started with a pilot that we spoke about, which we are calling in the national, the demonstration sites, which my colleague has already mentioned. Then we moved to, 4 other districts. And these districts were Chitambo, we moved to Chama, then we moved to Manyinga, then we moved to Vubwi. So the 4 were the first scale up in the first phase of our scale up. Then we had a second phase of our scale up where we also went again and implemented our activities in 5 more districts. So we went to Mwinirunga, we went to Petauke, we also implemented in Mansa, we also implemented in Kasama, and finally we implemented in Rufanyama. So you can see from the geographical map of Zambia that we were relatively well spread across the country, sampling all the districts from all corners. Of course, like I mentioned, we were in 7 provinces, but we are very sure that these 7 provinces were representative of different environments of what you expect to get across Zambia. So next slide. Our scale-up results at national level, I would say that we are glad as a project that RAS training has been integrated into the community case management training program, which is ICCM. So what this means is that going forward, the ICCM trainees will also get a component of pre-referral, rectal artisanate, severe management skills. So we are happy because the ICCM training program is well funded, as you may be aware. It's well funded by the government and many stakeholders in the malaria spheres. We are also want to mention that the Ministry of Health is now procuring rectal artisanate. As we are speaking now, we have adequate stocks of rectal artisanate. Initially, when the project started, it was us, the project that was procuring just for the stocks for those areas where we are implemented. But now we are, the ministry has procured, and the plan is to scale up the use of rectal artisanate across Zambia, but of course in a phased approach. Right now, the immediate plan for the National Malaria Elimination Program is to expand RAS activities from the 10 that we have been in to additional 26, with the future plan of covering the whole country. I also want to mention here that our project was involved in the quantification of antimalarials. Specifically, the government through National Malaria Elimination Program utilized our experience, and we used it in the forecasting of the quantities that are required for the procurement of RAS. As you can see on my right is just a depiction, or rather a copy of the integrated case management manual that is being used in Zambia. Next slide, please. I want now to talk about the drug supply. One of the things that we were monitoring as a project also was the supply of drugs. So what we did, we surveyed a percentage of health facilities that had 80% of the main malaria drugs available at that particular time when we were doing a survey. And the drugs that we're looking at the 4 major commodities for malaria. That is coartem, RAS, injectable artesunate, SP or Fancida and quinine. So basically our results showed that at baseline, we were at 35%. But you can see that on the graph that in the demonstration district, when we the end line showed that you know, we were 81% in terms of drug stocks in the demonstration district, and we were at 79% in the national scale-up district. So, you know, of course, you know, as expected, the pandemic, COVID pandemic really disrupted the movement of commodities across the world, including Zambia. So some of the problem that we faced in terms of drug supply, as you can see a drop there, was attributed to the effects of COVID-19. So some health facilities had shortages of injectable artesunates during 2020 when the pandemic, you know, was in full swing. However, as a project and working together with the health facilities where we are intervening, there was an initiative to make sure that, you know, WhatsApp groups were formulated so that information can be exchanged to be able to, you know, ascertain where there was enough drugs and where there were shortages, and that they used this information to be able to actually distribute the drugs to make sure that all the areas that we were intervening in had adequate stocks. Next slide. I will now draw your attention to the results that we achieved on our community health volunteers. One of the things that we wanted also to check on our community volunteers was, you know, the confidence, the knowledge. We were measuring the knowledge and the confidence levels of our community health volunteers. So as you can see there, you know, at baseline, we were at 8.7%. Community health volunteers that knew that the major severe malaria danger signs that knew at baseline, community health volunteers, the ratio was at 8.7, and at end line it had increased to 73%. So we also measured, took interest in finding out how confident our community health workers, volunteers were able to manage severe malaria at community level. So at baseline, you know, the confidence levels were at 79. At end line, there was an improvement up to, you know, we went up to 94. So we also looked at, you know, we also looked at, you know, the community health volunteers that said that they were able to follow up the cases of severe malaria that were referred to the health facility for onward reference to, you know, maybe for high to the higher, you know, health facility. So at baseline we were at 67, and at end line in all districts as an aggregate we were at 78. In the demonstration district we were at 94%. Clearly, this shows that you know, there's room for us to improve in the demonstration. I mean, in the national scale-up district. Next slide. I earlier spoke about the RAS verification exercise. Basically, what this exercise was simply for us to be able to measure whether our community health volunteers gave RAS correctly and patients received full treatment at the health facility. So we sampled, you know, 100 cases, which we reviewed in the 2 demonstration districts. And the things that we were looking at were the, you know, recording the danger signs observed on the patient. We also looked at the results on the rapid diagnostic tests. We also took interest to see whether the child was taken to the child was taken to the health facility and how long the whole process took. We also, you know, looked at what was the treatment that was given to the child, and finally we also, you know, looked at whether the child survived or, you know, unfortunately maybe the child, you know, died. But basically what you are seeing in that graph, I know it's a bit small for all of you to see, but those are the indicators that you are seeing. Those are the things that we are tracking that are listed there. So based on this, we concluded, we had, come up with conclusion based on this analysis. Next slide, which I'll share in the next slide. The conclusion that we were able to draw from this analysis, we could comfortably draw the conclusion that 95% of RAS recipients had severe malaria diagnosed, confirmed at health facilities. And this to us showed that our community health volunteers trained by the project were closely following the severe malaria protocol. We also concluded that 37% of the RAS recipients with confirmed severe malaria did not receive injectable artesunate due to stock out of the drug, especially during the COVID-19 pandemic. A similar exercise, which was carried in 2019, found that only 10% of the RAS recipients did not receive injectable artesunate at health facility level. And of course, this showed us that the pandemic really disrupted the movements of commodities across the country and the health facilities, which really affected the service delivery of, at primary healthcare level. Next slide. I will now switch to COVID-19 results. Interestingly, as a project, when we were just in the process of implementing our activities, we were hit like everyone else with COVID-19. And, we decided that we could be proactive as a project to use our already existing platforms and structures and systems to be able to respond to the COVID pandemic. So what we did, we also tried to adapt, our systems to be able to also engage and be able to fight, try and mitigate the effects of COVID-19. So what we did, we also included in our survey to just check on, our systems and our health volunteers. So you can see on the graph below there, you can see that they are preventive, indicators that we were monitoring, and on the prevention side, and also we were also looking at, whether the knowledge that this community health volunteer was adequate for them to be able to, help in the fight against COVID. So at, we were able to deduce that most of our community, 89% of our community health volunteers knew that a new continuous cough was a sign and symptom of, COVID-19. Similarly, 83% of our volunteers knew that fever was a sign and symptom of COVID-19. 85% also knew that difficulties in breathing was a sign and symptom of COVID-19. On the preventive side, at the end line, we also deduced that 96% of our volunteers knew that frequent washing of hands with soap and water was a preventive measure against COVID. Similarly, 83% knew that keeping 2 meters distance was a preventive measure. 60% and 40% respectively knew that not shaking hands and covering a cough was also a preventive measure for COVID-19. So all in all, more than 80% of our CHV knew that the 3 major danger signs of COVID-19 were the ones that I was talking about, and 79% of community health volunteers reported that the gender-based violence had disappeared or reduced a lot in the recent past after we engaged them in the training, as my colleague had earlier alluded, that we got engaged in trainings to make sure that we mitigate some of the effects that were associated with COVID-19. 5% of our community health volunteers reported that gender-based violence had increased because of COVID-19. So less than 4% of the community health volunteers indicated that they lacked PPEs. and only 1% indicated that they lacked formal training in COVID-19. So based on all this intervention, at endline, 52% of our community health volunteers, were, vaccinated against COVID, against the national vaccine coverage of 3.1% at 31st October 2021. Next slide. We also took keen interest in gender-based violence and social inclusion. This is where 95% of our community health volunteers said that they had a stronger voice at community level due to the training that we had given them. CHV also thought that women in their communities, after conducting all the the trainings and passing over the knowledge to the community, that women in their community had more scope for independent decision making as a result of the project activities. That is at endline, which was at 90%. We also looked at gender-based, which we said, the result was at endline, 84% of the community health volunteers who say that gender-based violence had reduced or disappeared over the last few years. We also looked at the issue of community health volunteers that had taken action to assist the least supported in the community. At endline, 90% of our community health volunteers said that they had taken action, or rather they had involved themselves to try and assist the least supported women in the community. As you may be aware that the least supported community members, especially women, carry the most of the burden of sickness in the community. So, our project, felt that it was very, very important for us to be socially inclusive. And that's why we are measuring all these, indicators to make sure that our approach was inclusive and was taken on board everyone. Next slide. Interestingly, that picture here there shows a family with their 2 children that benefited from our project. So from all the interventions that we've been talking about, for example, we had recipients of RAS in the pilot. We had 1,215, and at scale up we had 12,310 recipients of RAS. Those children that we are seeing with their parents on the picture are some of the beneficiaries of the rectal artisanate program that we have been implementing. Up to today, this family is very happy that they are not very sure what would have happened had we not introduced this innovation of the use of rectal artisanate at community level. So we also received a lot of transfers on emergency transport scheme that was community based. So at pilot, the total we had transferred was 1,552. At scale up, full scale, we transported 6,616, which represents from pilot to scale up 326%. As a project, we are very, very proud of these achievements and the sentiments that we are getting from the community about the benefits from the project that we implemented on pre-referral rectal artisanate. Next slide. We also measured the case fatality in our intervention sites. Malaria, as you know, is a killer disease, and in our demonstration districts, the fatality rate dropped from 3.1% to 0.1%, representing a reduction of 97%. In our scale-up districts, the reduction was 87% from 10.7% to 1.4%. So based on this and on a very, very conservative ratio, we estimate that through our intervention, we saved 496 lives attributed to the project intervention. We also estimate that 825 lives were improved based on all the different or various interventions that were put in place across all our intervention sites. Next slide. I will now, talk about challenges and lessons that we realized along the implementation of our project. One of the challenges that we faced was the stockouts of injectable artesunate, especially during 2020. As I mentioned, this was because of the COVID-19 pandemic. Also, there was an inconsistent supply of drugs for simple malaria, also based on the same reason, COVID-19. We also, were not able, rather should I say, the Ministry of Health was not able to fund the large-scale rollout of the emergency transport scheme system, which we had budgeted and spent a lot of time to evaluate. However, due to financial constraints during the Global Fund application, I think this is one of the component that was not picked up due to budget constraints. But we are very hopeful that the ministry going forward, together with other stakeholders, will be able to pick up this, because this is one of the components that is helping to reduce the barriers in accessing primary care, especially in very, very remote rural communities. We also encountered, a skewed gender-based balance. In terms of the selection of ICCM or community health volunteers, because when the government and the partners are training ICCM, they are training in ICCM. They get, those that are, volunteers that have been trained in ICCM, and most of them are men. So you find that in the areas, especially the national scale-up areas where we went, it was difficult for us to achieve a 50-50 balance, because most of the ICCM trained community health volunteers were male. However, we were able to try as much as possible to be able to, to work towards the gender balance. On the lessons learned, we learned through the project that building capacity to manage severe malaria at lower level health facility helped reduce barriers to access primary health care for communities. We know that in the area, in the southern region area, and maybe central, there are countries that are, strengthening, they are doing the strengthening of higher, facilities, or rather at hospital level, ignoring the, the facility level where, we feel that once that, that linkage between the facility and the community is strongly, made those linkages, it reduces these problems, and you find that the results that will come out from any intervention will be very strong. We also realize that training community health volunteers in community engagement and mobilization is just as important as training these community health volunteers in case management, because we noticed that without a strong community engagement system and mobilization, it is very difficult to be able to stimulate the demand for these primary commodities at the health facility level, for example, erector artesunate. So if community health volunteers are strengthened, they are given enough training to be able to mobilize and also to be able to raise awareness, it becomes much easier for the uptake of all these primary services at the health facility level to improve. And hence, by improving those, it means that the demand increases, and the disease burden is lessened. In short, health-seeking behaviors are improved. So the last one that we observed was, a well-trained community, is also very cardinal in a response to all challenges. For example, taking advantage of our strong community systems, we were able to quickly adapt and use our already existing structures to be able to fight COVID-19. I already, told you, shared with you the results that we got from COVID-19. But all those positive results were as a result of having a very strong and, motivated community, response system. So basically, those are the lessons that we got and challenges from our survey. Next slide. My presentation ends here. Thank you for listening, and I'll pass on the presentation button to my colleague Paula quickly, who is one of our senior advisor on the project. Paula, over to you. Thank you so much.
Thank you so much, Dennis. Obviously a lot of information there to absorb. I know some of you have been on previous webinars with us and may, so some of it maybe hopefully is familiar. And I know many of you are calling in from Zambia, so hopefully you also know a little bit about the program already. I think I've only seen one question in the chat so far, but just before we get to that, I know, Hans, that you have to leave on the hour. So I was wondering if you don't mind just giving us a few words of wisdom before you depart as a key partner. We know that, and you did mention it already in your opening, that there are different experiences with RAS, particularly around Africa. And of course, we've seen very good results in this program in MAMaZ Scale, also at the scaling up level. So not just in the demonstration, where of course it was a very intensive process and a lot of supervision and support given, but it also in the broader context, in contexts where there was much less support given directly to community health volunteers. And of course, we know from that last slide that one of the critical points is supporting those volunteers. There are obviously many parts to this that may make a successful outcome in terms of reducing child deaths and preventable deaths. So just what would be your advice to our partners in Zambia and elsewhere who really would like to try to replicate these results and scale up RAS programs in the context of a malaria response, and in terms of dealing with those different experiences that we're seeing and coming out in publications now? Thanks, Hans.
Thank you, Paula. And it is really a delight to listen to the team, Dennis, what you presented, and Kathy, about the results that actually show that primary healthcare, quality of care, can be delivered. And it, of course, does require an effort of making all the steps in the continuum of care work. But when one does that, one gets basically the results that we are all hoping for, and that is reduced mortality from malaria. And I would encourage everybody that is watching this webinar, if it's from other countries, to really very seriously consider the model that was just presented from Zambia, because with these ingredients at the community health volunteer level, the community engagement, ensuring supplies of critical commodities are there, the continuum of care, even the visits of the community health volunteers after the patient has been discharged from the hospital and is back in the community, that is indeed something that the WHO has been recommending for many years. And it is wonderful to see that in your work in Zambia, you're actually showing this can be achieved. So yes, I'm very optimistic that with that approach and mindset, other countries can definitely improve their quality of care for malaria patients. And this goes beyond malaria. This is not just for malaria. This is also for other childhood diseases, for pneumonia, for diarrhea, and for others. So I think it's a wonderful pathway to the primary health care for all objective. And so yes, indeed, there have been other kind of observational studies where the results weren't as strikingly positive. That has nothing to do with the lack of efficacy of these drugs. Unfortunately, it's the delivery mechanism that was proven to be deficient. And we don't need to accept that. I think we can do better. Zambia is an example. Thank you.
Thank you, Hans. Yes, absolutely. I think it shows the importance of just investing at community level and in the community, whether it's through volunteers, but also that primary healthcare system that really supports community level action. And then you can see results. And in fact, the MAM program grew out of a maternal and newborn health program. So, and it's one of the reasons I think why we are sure why it was so successful is because we built an approach that was already grounded in some of these communities, particularly in our demonstration district. So, you know, it's amazing what you can do when you invest at that level of the system and in people. So let's move on to the first question, and I do hope there will be more questions. Please do feel free to write in the chat, but we'll otherwise we might unmute everybody after this response, and then people can just please ask questions if you don't feel like writing in the chat, but otherwise put it in the chat and then everyone can see it. So the question comes from Abi Ramaj, who's a colleague of mine at DAI, who asks, how did you incentivize stakeholders at the district level to participate? So we'll give Dennis a little bit of a break since he spoke for so long. Kathy, would you like to take that one on as a starter? And it's such a shame that Ernest wasn't able to join us, but because he could give you a lot of information about that. But Kathy, over to you. Thank you.
Yes, absolutely, and a great question, Abby. Thank you very much for that one. Yeah, I think we sort of mentioned earlier that we've had a long-standing relationship with the two demonstration districts. We've been working in those two districts, Serenji and Chitambo in Central Province, since 2010. So when the severe malaria project started up, there was that sort of ongoing relationship to build on. The fact that we had two demonstration districts and could invite stakeholders from other districts, other provinces, national level to see the work in action was also very helpful. And you know, by the time we scaled up to the 8 scale-up districts, you know, the DHMTs had heard about the project and what it had been doing in the 2 demonstration districts. And to be honest, you know, there was no need for any incentivization. The door was open and ready for us to come in and work with the district health management teams there. They were very positive and very welcoming. Thanks, Paula.
Yeah, thanks, Kathy. And we did hope to have some government representatives from the National Malaria Elimination Council with us, but unfortunately, similar to Ernest, our technical coordinator, they're having some technical challenges logging in. So Dr. Bwalia was logged in at the beginning. I'm not sure if he's logged in as a participant now, but he was logged in earlier and was going to say a few words later. But in the meantime, I don't know if there's any other participants from Zambia who have any questions or comments, who are, you know, running similar programs or thinking about similar programs or working at community level, if they have any comments or feedback they'd like to offer. And I don't know, Shani, if you've managed to unmute everybody so people could just unmute themselves, or give them the option to unmute themselves.
Hello, good
Hi,
afternoon.
this is
Yes, please.
go ahead.
This is Donna Mkumbuta from National Malaria. I've just joined it, and we are very busy here because we are doing our harmonization planning, trying to put things for 2022 year calendar. So we are just shuffling from one Zoom to another.
Well, thank you very much for taking the time, Dr. Mkumbuta. You're showing up as Dennis because you've obviously linked in with his connection, but we know you're not Dennis. But it's a real pleasure to have you here. Would you like to say a few words about the National Malaria Programme in Zambia and about the RAS component in particular?
Yes. Hello?
Yes. Can you hear us okay? Would you like to say a few words about your experience of the RAS implementation in Zambia at community level and its sort of place in the national malaria response?
All right. What I can say is we were very pleased to have the support from MAMaZ, as well as the 2017 which I was privileged to participate from the initial stage of the project in Serenge, starting with the pilot that we had for which ran for in mortality. Then from there, after initiation of the project, we saw wonders with the program. Yeah, what a lot of staff who participated there, district staff from Serenge, as well as also the MAMaZ, the project staff, plus NMEC, who are the holder of the program malaria. We combined our effort and we saw the outcome of the project. It was really wonderful. And from there, 2018, 2019, the program was extended to another district, adjacent district, which was Chitambo. And from that, let me just say from the inception, the first pilot, immediately it finished, there was a decision at National Malaria to ensure that we enshrine these good results that came out into our treatment guideline, and also to escalate it at policy level to accept this program and the activity and the drug itself as one of the medicine that will help in reducing the mortality in the country. So the treatment guideline that we produced in 2017 actually included those recommendations, and from that time, that is how it became a national program, because it was accepted policy-wise. And then from there, we had to start the work of scaling up. And together with our partner, we really did a tremendous work in and out. Kathy Greene and the team used to come, and we used to meet time and again, sometimes in Lusaka, sometimes in Serenge, up to Chitambo district. For the past 3 years, I can attest to the fact that the program has been really a success in the country. And then by 2020-21, we had to embark on scaling the program with MAMaZ to other provinces, and we managed to take it up to 10 districts, where it is spread into different provinces. We had 2 districts that we got from Northwestern, and another 2, one district in Luapula, another district in Northern Province, and then 2 districts in Eastern Province, plus those traditional districts that we had in Central Province. So in total, by the time when our partner was winding up with the project, we had almost 10 districts where we have rolled out these activities. Yes, and from there, the government itself had to take it upon itself now that to start procuring this RAS. As we are ending up this last year, we were in 245 districts. That is how far we have gone with the program. The program, in summary and in a nutshell, we can say it has been really a success. Thank you. I submit.
Thank you, Dr. Mukumbeta. That's fantastic. And could you just tell us a few words about the plans for further scale up from the government side, from NEMEC side? Thank you.
May you come back again on the question?
Could you just let us know what your plans are for further scaling up of the availability of RAS in more communities?
All right. It is the intention of the government to continue scaling up, because even the medicine, the drug that has been procured is still enough to continue. Where we ended last week, that last year, by December, we were talking of 45 districts. We still felt that as we continue training community health workers, because community health workers are the precondition to which we can procure. So we have in the plan to ensure that as we train, wherever we are training, we need to ensure that actually we also distribute the rectal testnet. Yes, however, something that we still need help is on the social mobilization part, so that acceptance can go together with the part of distribution of the drug and case management part. But if at all we can have something really to strengthen the component of SBCC, that on the component of social mobilization is the one that we are lacking. Us who are dealing with ICCM, we would have loved the package, the way it was handled during the pilot, and also the scaling, the implementation of the drug, the drug in 2 districts, the Serenge and the Chitambo, because there were 2 types of community health workers who were being trained by Kathy Green and the team, whereby those administering the medicine, as well as also the social mobilization component for acceptance of the community or awareness of the activity. And now, as it is growing on scale, because of lack of resources and also specialization, at national level, we handle specialization. Myself, who is talking here, we are dealing with the training and also case management part. As we go now, as we bring it at national level, there's that specialization whereby the social component, the social mobilization component goes together into the social behavior change communication unity. And now it means it forced us to split. It forced us to split the program in the way it was designed at pilot stage. But nevertheless, we didn't like to lose sight. Even before the Kathy Green and MAMaZ team, before it phased out the project, we discussed that part to say, at national level, as we want to get this, there is a component of specialization, which means the way you handled it, it means it has got 2 areas, case management as well as social mobilization. So we want this to be handled by specialized people. But now the specialized part on the social mobilization, they didn't have that a lot of experience. Yes, a lot of experience, so that even us who are pushing the drug in terms of case management would have been moving together, would have loved to move together wherever, so that at least the component of social mobilization should not remain behind. But I feel maybe there's need to do more on that part in terms of capacity, as well as also to ensure that these things move together. I submit.
Thank you so much, Dr. Mukumbuta. It's a really good point, and we know it is very challenging for governments. If it wasn't so challenging, then it would have been done a long time ago, right? So we know that this is difficult and it is resource intensive. To
yes.
Put a lot of effort at the community level, and especially, as you say, many people in the government and in the disease management programs, they don't necessarily have those social mobilization skills. So it's really important to bring those into the team, or to work with partners who have them and bring things together. But we know that's really challenging, and we hope that we have been able to give a flavor of how it's possible in MAM Scale and the former MAMaZ programs, and what benefits you can get from really investing at community level. But we are, well, I think every country in the world is struggling with this. So it's great that you're very committed and willing to work together with partners who have those skills. I think we're getting another question about the emergency transport scheme, and that is, how can we find out more, especially on the bicycle ambulance? That seems to have been a game changer. Carol, would you like to answer that question from Tanzania?
With pleasure. Thank you so much.
Yeah, just to.
Sure.
All right. Just to comment on the emergency transport system. It's one of the unique enabler. We call it enabler. It's one of the unique enabler that actually facilitate the work. It is unique in this project. Yeah, it is unique in such a way that, yes, we are having different partners, but they sometimes end up at just having bicycles as just, but the way MAMaZ handled it, yes, it has been providing also bicycles, but that component of That bicycle, which had an ambulance also, it is something that was very much appreciated, even when it was brought on board, and also after pilot, the end of the pilot, when they were brought for consensus at national level, it was something that was very interesting, and something that we still need help through partnership. Thank you. Just on that comment of what the whole entire project was something that is very interesting, really. Yeah.
Thank you. Cara, would you like to come in on behalf also of Disicare, our partner who also wasn't able to make it today?
Absolutely. Thank you so much, Mr. Mukumbuta, though. I mean, I think you said everything really in terms of, I do also believe that it was quite a unique approach by integrating the emergency transfer with using the bicycle ambulances that colleagues have spoken about. And we saw some of the really quite impressive results. Over 6,000 children transported by the bicycle ambulances.
Yes.
So there's a high demand and uptake, which is fantastic. If people want to find out more, we will be sharing the presentation. We will be sharing the technical brief and other materials, contacts. And really a big credit to Disicare, our partners who constructed and built the bicycle ambulances, and for over a decade have been taking the care to get feedback on the design, enhancing and improving in a lot of consultation from all partners. So this is a wonderful Zambian-based organisation. We can provide in the if anybody wants to find out more, we'd be delighted to make those connections, and also to appreciate the work that World Bicycle Relief are doing as well. We procure their buffalo bicycles, really strong and fast for the terrain.
Thank you. Thank you.
Thanks, Cara. We have a little bit of interference on the line, so I hope everyone could hear okay. I believe Paul Sakis, that you have your hands up. Paul, I hope you can unmute yourself and ask your question.
Yes. Hi, good morning, good afternoon. Can you hear me okay?
Yes, absolutely.
You know, and let me give a shout out to Mr. Mukumbuta. You know, he's such a great champion for community case management of malaria in general, and now with the RAS component as well, and we work closely. Well, PMI is, as you may know, one of the partners that's committed to try to take advantage of this pilot in Serenge and the continued expansion, and trying to help Zambia to further roll out RAS, both in terms of procuring the rectal artesunate and also through our PAMO Plus project, which is PATH, to actually provide technical assistance at the district, you know, and provincial level. A question I have, and it's honestly just really a question, is if you look at the track record of rectal artesunate since, I believe, 2009, when WHO gave the green light, it's been mostly a history of failed uptake, right? So you'll see enthusiasm, but then you don't actually see a whole lot of referrals going on and a whole lot of impact. And the pilot and the initial years here seem to show a way where if you coupled the training and the provision of rectal artesunate with that emergency transport system, and not the bicycle ambulances themselves, but also the whole sort of, you know, as Donald says, the community mobilization, the food banks, you know, et cetera, et cetera. There's a lovely video supported by MMV Gates that captured this quite nicely up. You know, that seemed to be, well, maybe that's the magic ingredient, you know, and this is the case where you had, through safe motherhood investments, you had, as was alluded to, kind of a culture of this going on. And so in Chama district in Muchinga, we, through PAMO Plus, with MAMaZ still there, tried to scale this up. And I think it went pretty well, but it's fairly laborious. So we have a lot of questions, honestly, about the scalability of this. Getting these bicycle ambulances out there, getting the system going, seems to really be slowing down the process. And yet, is it the key ingredient that will be necessary? So I'm encouraged to see that, you know, in these 10 districts, you found impact on case fatality rates. Obviously, we'll want to study that data carefully, but that's very encouraging that even on a larger pilot scale, you were able to see that. So what are the key ingredients? How do we avoid the kind of track record that RAS had over the years? How do we keep momentum going in Zambia? Again, we're a donor, we're standing by, we've got some resources, we've got a million competing demands, of course, but we are trying to do our part. So what are going to be the key ingredients, assuming that we can't replicate, the full Serenge pilot? Over.
Thank you, Paul. Well, the million-dollar question, isn't it? Or a bundle of questions. How do you keep it going? How do you scale it up effectively? I don't know who'd like to take that on. I mean, I think it is important to know, though, that we did have many communities that did not have a bicycle ambulance, and we had many that did. So it's not the only thing, but it's really important in those communities that are particularly disadvantaged in terms of access to a health facility. But Kathy or Carol, I don't know, or Dr. Mr. Mukumbuta, who would like to take that one next? Just 1 second while we unmute you, Mr. Mukumbuta. There was some interference. Shali, you can just unmute. Thanks. Go ahead, Dr. Mukumbuta. We can hear you now.
All right, okay. I'll just like what Paul has said. Oh, sorry, there's something that has just. Oh. Yeah, sorry, something just on the laptop. Are you getting me? Hello?
Yes, we are. Yes, go ahead, please.
Yeah, just like what Paul has said, Dr. Paul Sykas. Yeah, is something that we appreciate very much as a NMEC, especially that when you have partners who understand your program and are willingly to support the government program, and all of a sudden, maybe the project ends, it leaves a big gap. It really leaves a big gap to the program for us to fill in, so that at least we can continue with the momentum. It becomes a little bit of a big problem for us. Just like as I've said, we have mentioned on the transport, emergency transport system. PAMO through USAID have tried there in their demonstration in the district, that is Chama, to replicate what was happening in Serenge and also Chitambo. And also from there, would have loved that such kind of the model, the way it was designed in Serenge and whatever, it could have gone countrywide. But now when it is submitted at the government level, we look at the bigger picture and also the resource envelope. And that's why we find that we start now demarcating to just do it once, while we appreciate the whole entire component, but you could find that the resources also comes on our edge. No wonder you find that even as we spread it, as we are scaling it up in the country, we are lacking in terms of who can assist us with it. Emergency transport, in the way it has produced results in Serenge and Chitambo. Would have liked that even in the 45 districts where we are talking of, we would have loved to see all that flavor, that kind of scenarios, experience that we have seen in the 2 districts and even plus Chama, which was taken by USAID. So just as I've said, the part of emergency transport as well as also social mobilization component. These are the 2 things that is to demand a lot of resources for us to see a good outcome of the program itself. I submit.
Thank you. Thank you very much, Mr. Mukumbuta. Kathy, did you want to add anything?
Yeah, I mean, I think the point is that we often talk about implementing in real world conditions, and I think what we need to remember is that we need to acknowledge the real world conditions that, through the eyes of the community. So we do need an approach that addresses the barriers and the delays that they face. You know, it's not just about case management, it's not just about strengthening the health system. We need a strong community health system. We need mobilized and empowered communities. That's absolutely fundamental. And, you know, I think Paula has sort of mentioned that the ETS, so the emergency transport system, wasn't implemented everywhere. But I think, you know, there are some basics that need to be implemented. We do need, you know, a big focus on community mobilization aspects of the training within the ICCM training of community health volunteers. You know, it's not enough to train them on, you know, how to store RAS, how to administer RAS, how to recognize danger signs and how to follow up patients. They really do need the skills to mobilize their communities. But we're not talking about a huge input here. We're talking about a relatively modest training which gives them just enough so that they can, you know, go back to their communities and really empower and mobilize. The work on food banks and emergency savings schemes, again, it's not a huge initiative, and, you know, with a relatively small input, CHVs have done a really great job of setting up those schemes. So I think, you know, perhaps we need to sort of change the way that we describe this a bit and use slightly different language and talk about, you know, the real world conditions that the communities face, because they are the users of this product, and that's fundamentally important. But happy, Paul, to share information. We've got some data on what we did in what we call high intensity sites and what we did in low intensity sites, slightly different approaches there, and we can discuss those different approaches with you and share the data on those. Over.
Thanks, Kathy. And just related to communities, we have a question about how did you define communities? Are those villages or neighbourhood health committees? So I think it's the latter. But Kathy, do you want to say a word about the communities?
You're correct on that, Paula.
Yeah. So yeah, that's the definition we use. We also had a quick question about the ICCM training is 6 days. What is NEMEC's guidance on the number of days when RAS is integrated? So we've got two sides on that, but Mr. Mukumbuta, perhaps you want to come in first on that one about, you know, how long the training is when RAS is integrated. Oh, just let us unmute you. Hang on a second. Shadi, can you unmute Mr. Mukumbuta, please?
All right.
Thank you.
Yes.
Right.
Are you getting me now?
Yes,
all
we
right.
can hear you. Go ahead.
Yeah.
Thanks.
When we hello, are you getting me? Hello. All right. Okay. When we had experience from the two districts, we had some discussion with other partners who were interested in the program, and that was the USAID PAMO. Yeah, and it's where we started some suggestions to see the way forward of how we can handle the program as we are scaling it up. And the decision was to try to see how we can combine it or add something like a day to ensure that actually we discuss issues to do with the RAS implementation and the training aspect of it. So like when we went to Chama under the region where USAID operates, PAMO, we added a day. We added a day there. It made 7 days to ensure that part of the administration of the drug were discussed during the 6-day training. But that 7th day was a special day whereby at least we could demonstrate through body language and other things so that at least they can be added in that day. Even when we did that, it was not enough. That's why we made it just, this is scenario 1 or scenario 1. The scenario 2 also, you could, if resources allow, we could have allowed even 2 days or even 4 days, like what we did when we scaled it in 10 districts. We took it at a separate, people were already trained some time back, but we had to call them and also to have a 2-day, that was scenario 2. So in all, you could find that it's just the resources and the time that does not allow us. But otherwise, the program itself needed more days. But at least we had to implement it. We tried it. We experimented it in adding 1 day as well as also another scenario too. We handled it separately. Of those people who have already been trained, we had 2 days, and that is how we tried to ensure that actually those who have already been trained and those that were being trained, we could add value or add the component of RAS in those trainings, and that is how we handled it.
Thank you very much. Yes, and of course, it's always a balance between getting people's time, the trainees and the trainers, having the funding to do it, and to do, obviously longer training is better in many ways, but there's also, there's only so long that you can keep people away from their communities or from the health facilities, for example, when people are training. So it's always a balance in terms of that. And there may be different contexts where you can do it a little bit quicker if people have some previous experience of social mobilization, or if you're really starting from scratch, you need to invest a little bit of more time. That's what we've also found. So where people really haven't had any exposure, 1 or 2 days is really short. But you do what you can within the constraints that you have. I know we're nearly at time. There are a couple more questions about scaling up, which I think we've touched on already, and about MAMaZ plans, which you've already spoken about, Mr. Mukumbeta, and also about what was the real critical ingredient to success. And I think there's no easy answer to that. We've discussed it a little bit. It really depends a little bit on context and on specific circumstances in any community, what has more or less value and need, and what's more of a priority. The package is, we feel, ideal, but there are some elements of the package that are more important in certain contexts compared to others. So it's always really context specific is the real answer. And of course, you need some core ingredients. You need the drugs, the medication. You need qualified staff at the health facility who will receive a child, who will implement the proper management. You need the other drugs there. You need the injectable artesunate. You need the ACT. You need the community volunteers to do the follow-up. So you may need transport to get there and to get back. So, it's really is a combination depending on the context. But Carol, I'm going to hand back to you. Thank you so much, Mr. Mukumbeta, for all your contributions. It's been really valuable to represent the government of Zambia and NEMIC. Thank you so much. And
thank you.
Back to you to finish up. Thank you.
Thank you so much, Paula. In our last 30 seconds, all that remains is we're just putting the note in the chat, really, but a very big thank you from the MAM Scale team for all of your efforts, for everyone who's joined today. Thank you so much. We're really, really pleased and proud of the work and everybody who's made it possible. We'll be sending information, links, recordings out. And thank you again, and stay safe. All the best.